Though most of the manifestations of acute rheumatic fever do not leave long-lasting sequelae, carditis is different. Carditis can resolve without sequelae in a few cases, but most often it leads to valvular lesions which are progressive. The most commonly involved valve is mitral valve, and mitral regurgitation is the commonest lesion in acute rheumatic fever. Stenotic lesions do not occur in the acute phase as they take a long time to develop by progressive fibrosis. According to Paul Wood, the frequency of involvement of valves in rheumatic fever is related to the hemodynamic load on the valve. In this respect, mitral valve has the maximum load, followed by aortic, tricuspid and pulmonary in that order. Mitral valve faces the systolic left ventricular pressure in closed position, and aortic valve faces the diastolic aortic pressure in the closed position. Rheumatic mitral regurgitation manifests clinically with a pan-systolic murmur at the apex radiating to the axilla and back. It is often associated with a left ventricular third heart sound. The radiation pattern of the murmur is due to the posterior direction of the mitral regurgitation jet, as the predominant involvement is that of anterior mitral leaflet. Mitral leaflets are thickened and the closure is incomplete, leaving a regurgitant orifice. The size of the regurgitant orifice increases as the severity increases. Color Doppler echocardiogram in rheumatic mitral regurgitation. Posteriorly directed mild mitral regurgitation jet in bluish mosaic color extending from the closed mitral valve to the posterior wall of the left atrium. This is a left parasternal view with the echo beam coming from the top of the image. So posterior structures will be at the lower part of the image. In color Doppler echocardiography, flow directed away from the echo transducer will be coded blue. Chronic mitral regurgitation can progress over the years. Mitral regurgitation produces dilatation of the left atrium and left ventricle due to the volume overload. Left ventricular dilatation enlarges the mitral valve annulus, preventing the proper coaptation of the mitral leaflets. This causes worsening of mitral regurgitation. This is often called MR begets MR. Severe mitral regurgitation produces a forceful left ventricular apex with cardiomegaly. Acute mitral regurgitation in the setting of acute rheumatic fever can regress as the rheumatic fever subsides. It may disappear completely or persist partially as chronic mitral regurgitation. Chronic rheumatic mitral regurgitation is often asymptomatic until the left ventricle starts to fail due to progressive dilatation and fibrosis. Since it's a volume overload lesion, palpitation may be the initial symptom, followed by exertional dyspnea and other features of heart failure later. Onset of symptoms is late in mitral regurgitation as the left ventricle has two outlets in this condition, that is left atrium and left ventricle. For the same reason, by the time severe symptoms occur, there may be irreversible fibrosis in the left ventricle. Such cases may not improve even after surgical treatment. Severe symptomatic mitral regurgitation not responding to medical treatment can be repaired surgically or replaced with a prosthetic valve. Recently, catheter-based non-surgical repair using specially designed clips to reduce the regurgitation has been innovated. Rheumatic mitral stenosis develops a long period after the acute episode of rheumatic fever, as it takes a long time for fibrosis and mitral valve narrowing to set in. Commissural fusion is the hallmark of rheumatic mitral stenosis. It is associated with a varying degree of fusion of the subvalvular apparatus called as subvalvular pathology. Caudate antennae are shortened and fibrotic. This often produces a secondary obstruction below the mitral valve. Long-standing cases have been associated with calcification of leaflets and subvalvular pathology. Rheumatic mitral stenosis may take decades to develop in certain cases. The following chronological classification can be considered. 1. Juvenile mitral stenosis. Onset before the age of 20 years, the term coined by Professor S.B. Roy, seen mostly in developing countries. Hemoptysis, calcification of the valve, and atrial fibrillation are less common in this age group, but they have a more severe clinical course. 2. Adult onset mitral stenosis. This was the standard pattern seen in the Western world, with onset of symptoms of mitral stenosis occurring in the third or fourth decade. 3. Late onset mitral stenosis. This is a relatively new group which has been noted in the West with initial manifestation in the elderly. Pathologically, the mitral valve in mitral stenosis has a classical fish mouth appearance. Cross-sectional view of the mitral valve on echocardiogram in mitral stenosis is shown here. Mitral orifice is marked as M and has a fish mouth appearance. Please note that the mitral leaflets are thickened and the commissures are fused. In long-standing severe mitral stenosis, left atrium enlarges and pulmonary venous pressure increases. Increase in pulmonary venous pressure is transmitted back to the pulmonary arteries, producing pulmonary arterial hypertension. This in turn produces right ventricular hypertrophy. Severe right ventricular hypertrophy and failure leads to tricuspid regurgitation and right atrial enlargement. The predominant symptom of mitral stenosis is exertional breathlessness due to pulmonary congestion. Mitral stenosis may manifest as episodes in the night known as paroxysmal nocturnal dyspnea. Other symptoms are hemoptysis due to rupture of bronchial veins or pulmonary infarction and palpitation. Atrial fibrillation, which occurs in chronic cases, may contribute to palpitation and precipitation of heart failure. Clinical findings in mitral stenosis includes a loud first heart sound, opening snap, and mid-diastolic murmur with pre-systolic accentuation. Opening snap becomes inaudible when the mitral valve is calcified. Pre-systolic accentuation is absent when there is atrial fibrillation. Left parasternal heave and loud pulmonary comment of second heart sound or P2 can be noted when there is severe pulmonary hypertension. An early diastolic murmur of pulmonary regurgitation known as Graham-Steele murmur can also occur in severe pulmonary hypertension. Pansystolic murmur of tricuspid regurgitation may be noted along with this. In the yesteryears, severe mitral stenosis used to be treated with closed or open mitral valvotomy. Severely calcific valves are replaced with prosthetic valves. For the past few decades, catheter-based balloon mitral valvotomy, otherwise known as percutaneous mitral commissurotomy, has become the first option for mitral stenosis with pliable valves which do not have dense calcification. Those with atrial fibrillation need anticoagulation as they are highly prone for thromboembolic events. Rheumatic aortic regurgitation can occur in the acute phase of rheumatic fever and disappear later. In the chronic stage, it may progress in severity. Peripheral signs of aortic regurgitation are noted in chronic severe aortic regurgitation due to the rapid aortic runoff along with peripheral vasodilatation. Peripheral resistance is reduced in an attempt to reduce regurgitation and encourage forward flow. High volume collapsing pulse is a characteristic of severe aortic regurgitation. Echocardiogram in severe aortic regurgitation is shown here. Echocardiogram from the parasternal region showing the high velocity mosaic colored aortic regurgitation jet from aortic valve to the left ventricle marked as AR jet. Both left atrium and left ventricle are dilated in severe aortic regurgitation. Initially, the left ventricle dilates and tries to accommodate the regurgitant volume. In addition to dilatation, there is hypertrophy of the left ventricular wall. This is known as eccentric left ventricular hypertrophy. As time passes, this compensatory mechanism fails and left ventricle starts failing. Left ventricular muscle can develop fibrotic changes which indicate irreversible late stage. Clinical findings in aortic regurgitation include high volume collapsing pulse, cardiomegaly with a forceful apex and a high-pitched, blowing early diastolic murmur heard in the aortic area and along the left sternal border. A mid-diastolic or presystolic murmur in the mitral area due to flow across a functional narrowing of mitral valve in aortic regurgitation is known as Austin-Flynn murmur. Peripheral signs of aortic regurgitation are mostly due to the high stroke volume and high pulse pressure. They are noted in severe AR called as free AR. These are features of aortic runoff and can occur in other situations of aortic runoff like a ruptured sinus of Valsalva into right atrium. Now we will review the peripheral signs of AR. 1. Arterial pulsations in the retina. Normally there are only venous pulsations visible on the ocular fundus. In aortic regurgitation, retinal arterial pulsations are visible. This is known as Becker's sign. 2. Hill sign. Significant difference between the upper limb and lower limb blood pressure indicates significant aortic regurgitation. A difference of 20 to 40 millimeters of mercury is taken as mild, 40 to 60 millimeters of mercury as moderate, and above 60 millimeters of mercury as severe. This is one of the most sensitive signs of aortic regurgitation. 3. Muller's sign. Systolic pulsations of the uvula in AR. 4. Dancing carotids. Prominent carotid arterial pulsations due to the wide pulse pressure in AR is known as Corrigan sign. 5. Demusset sign. Head nodding sign in aortic regurgitation. 6. Bispherians pulse is more suggestive of free AR than a combination of AS and AR. Bispherians pulse has two peaks in each systole. 7. Locomotor brachii is a prominent pulsation of brachial artery seen in aortic regurgitation. It can also be seen in elderly individuals without aortic regurgitation. 8. Collapsing pulse or water hammer pulse is noted in the radial artery with upper limb lifted up passively and felt by the palm of the hand. Water hammer was a toy in the Victorian era in which fall of water in a vacuum tube produced a characteristic feel. 9. Quinge's sign. Prominent nail bed capillary pulsations. 10. Turosis murmur bar sign. A stethoscope kept over the femoral artery picks up a systolic murmur with proximal compression and a diastolic murmur with distal compression. The diastolic murmur is more specific. 11. Pistol shot sounds can be heard over the femoral arteries and sometimes over the brachial artery, known as Trop sign. 12. Gerhardt sign. Hepatic pulsations in severe AR. 13. Rosenbach sign. Splenic pulsations in severe AR. 14. Main sign. Exaggerated decrease in diastolic blood pressure of more than 15 millimeters of mercury on raising the upper lip, but the validity has been questioned as this can be noted in younger age without AR. 15. Lincoln sign. Prominent popliteal artery pulsations. 16. Sherman sign. Prominent dorsalis pedis artery pulsations. Aortic stenosis in rheumatic heart disease seldom occurs alone but in combination with aortic regurgitation or other valvular lesions. Isolated aortic stenosis is most commonly congenital in the younger age group and degenerative in the elderly. In severe aortic stenosis, the left ventricle hypertrophies as a compensatory mechanism. The type of hypertrophy is known as concentric left ventricular hypertrophy. In concentric left ventricular hypertrophy, there is thickening of the left ventricular wall without enlargement of the left ventricular cavity. In late stages, as the left ventricle fails, the cavity may dilate. Important symptoms of aortic stenosis are effort angina, exertional dyspnea, and exertional syncope. Effort angina occurs due to the mismatch between coronary arterial blood supply and the demand of a hypertrophied left ventricle. Exertional syncope occurs due to fixed cardiac output. When there is peripheral vasodilation with exercise, The fixed cardiac output causes cerebral hypoperfusion and syncope. Important physical findings of AS include a slow rising low volume pulse, that is pulsus parvus et tardus, heaving apex beat, that is sustained and forceful, soft aortic component of second heart sound, ejection click and an injection systolic murmur in the aortic area. The murmur of AS is conducted to the carotids and may be associated with a thrill in the aortic area. It may be necessary to feel in held expiration to feel a less prominent thrill. Ejection click of aortic stenosis is non-phasic with no significant variation with respiration. Echocardiogram from left parasternal region showing thickened and doming aortic wall in severe aortic stenosis. Left ventricle is hypertrophied as evidenced by the thickened interventricular septum. Severe symptomatic aortic stenosis can be treated by aortic valve replacement either with a mechanical prosthesis or a bioprosthetic valve. Recently, transcatheter aortic valve implantation, also known as transcatheter aortic valve replacement, has been introduced as a novel therapy. This approach is growing momentum, though a bit expensive currently. TAVI has been done mostly for the degenerative aortic stenosis of the elderly than rheumatic aortic stenosis. Any procedure for aortic stenosis has to be done before the left ventricle starts dilating due to irreversible fibrotic changes in the left ventricular myocardium. But as aortic stenosis is an afterload mismatch condition, the chance for improvement is more than in aortic regurgitation of corresponding severity and left ventricular dysfunction. In aortic stenosis, the left ventricle has a chance of recovering once the afterload mismatch is removed. Moving on to rheumatic tricuspid regurgitation. Rheumatic TR is almost always associated with mitral valve disease. Organic TR is often superimposed on hypertensive TR, which occurs due to pulmonary arterial hypertension secondary to mitral valve disease. Tricuspid leaflets are thickened and deformed by the rheumatic process, which leads to incomplete coaptation and tricuspid regurgitation. Clinically, TR is manifest as prominent systolic wave in the JVP, that is CV wave, pansystolic murmur in the tricuspid area increasing on inspiration, that is known as Carvalho's sign. Carvalho's sign may be absent when there is severe heart failure. This is because there is no significant respiratory change when right heart is already grossly congested. Similar situation occurs when there is associated tricuspid stenosis with high right atrial pressure. Systolic hepatic pulsations are felt in severe TR. Associated signs of pulmonary hypertension like palpable and loud pulmonary component of second heart sound or P2 is present, along with a left parasternal heave due to right ventricular hypertrophy. Echocardiogram in severe TR taken in the apical four-chamber view. Severe TR is seen as a large mosaic multicolored jet filling more than half of a dilated right atrium. Right ventricle is also dilated. While hypertensive TR may recover once the mitral valve lesion is addressed by valvotomy, repair or replacement, organic component of TR remains. It may be often difficult to assess how much of TR is organic and how much is likely to reverse after mitral procedure. Transcatheter repair of tricuspid valve in high surgical risk candidates are being reported. Earlier, repair of tricuspid valve was using a Carpentier annuloplasty ring. This used to be done mostly during open heart surgery for repair or replacement of left-sided heart valves, usually mitral, and seldom as a standalone procedure. Most cases of severe TR needing repair are secondary to mitral valve disease and severe pulmonary hypertension, and hence this approach was fairly frequent. Tricuspid annuloplasty can also be done without using a ring known as de Vega procedure. Rheumatic TS is often associated with mitral valve disease. As in rheumatic MS, there is commissural fusion in rheumatic TS. Androseptal commissure between the anterior and septal leaflets of the tricuspid valve is one which is most commonly involved. Tricuspid valve being the largest valve in the body, a gradient of 2 mm of mercury across it will qualify for tricuspid stenosis. A gradient of 5 mm would mean severe TS, whereas the corresponding gradient in severe MS is 20 mm of mercury. Severe TS causes right atrial hypertrophy and prominent A waves in the jugular venous pulse, known as giant A waves. Slow Y descent is another feature as right atrial emptying into the right ventricle is impeded. A presystolic hepatic pulsation may also be felt in severe tricuspid stenosis. Tricuspid opening snap increases with inspiration and is heard in the lower left sternal border. A mid-diastolic murmur in the tricuspid area is heard in TS. Ascites disproportionate to pedal edema, known as ascites precox, can occur in TS or TR. Hepatomegaly may be noted secondary to high right atrial pressure with dilated inferior vena cava. This can lead on to liver dysfunction as well. Balloon tricuspid valvotomy, a catheter-based technique, is sometimes used to relieve tricuspid valve obstruction. Unlike balloon mitral valvotomy, tricuspid valvotomy does not require puncture of the interatrial septum. The venous access is usually through the right femoral vein. The procedure is often done along with balloon mitral valvotomy, as tricuspid stenosis is almost invariably associated with mitral stenosis. Surgical treatment of tricuspid stenosis is opted for when there is need for concomitant mitral or aortic valve surgery. Surgical treatment is also needed when TS is associated with significant TR, which is often the case. Chance for thrombosis of the prosthetic valve is higher because of low flow velocity across it being a right-sided valve. Organic rheumatic pulmonary valve disease is extremely rare. It has been reported along with disease of other valves like a case of quadri valve disease. Pulmonary valve involvement in this case was less severe than that of aortic valve involvement. There was pulmonary stenosis and regurgitation in that case. Some other cases of quadri valve involvement in clinical and autopsy series are also there. A much more common situation is hypertensive pulmonary regurgitation in mitral valve disease with severe pulmonary hypertension. This is associated with loud pulmonary component of second heart sound, which may also be palpable, and a blowing early diastolic murmur in the pulmonary area known as Graham-Steele murmur.